So I'm Alyssa Achong Lau, your Medcorp Limited host for today. Welcome to our live webinar series, Connection and Care in an Era of Social Distancing. Today, we'll be discussing the novel coronavirus and cardiac disease with Dr. Rishi Rampasad. Dr. Rampasad is the Director of Cardiology, Research and Education at Caribbean Heartcare Medcorp Limited. He attended McGill University in Canada, the University of the West Indies, and Ascardio Cardiovascular Teaching Hospital in Venezuela. Dr. Rampasad is a member of several international cardiology societies and a fellow of several bodies, including the American College of Cardiology, the European Society of Cardiology, the Inter-American Society of Cardiology, and the Society of Cardiovascular Angiography and Interventions. Since starting work at Caribbean Heartcare Medcorp in 2005, Dr. Rampasad has established its cardiology and interventional cardiology departments, as well as its interventional neuroradiology, electrophysiology, and structural heart disease programs. He also created and worked on the first primary angioplasty team in Trinidad and Tobago, and he's worked with the team responsible for implantation of the first TAVI in the Caribbean. Dr. Rampasad, welcome, and thank you for being with us today.
Thank you, Alyssa, for that great introduction. As you know, we have been hit with one of the most cataclysmic events of the last century that has taken lives and is continuing to take lives. COVID-19 continues to affect persons of all ages, but seems to have a greater death rate and morbidity in persons affected with cardiovascular disease. I would like to take first and say thank you to all the medical, hospital personnel and essential services in the public and private businesses that have been helping to keep Trinidad and Tobago going. And to these heroes, I thank you and stand by you in the front lines. And my condolences to all the families in the world who have lost one, because to this date, we have 1.2 million people infected and over 68,000 or 69,000 deaths now. So what does COVID-19 do to the heart? COVID-19 is caused by severe acute respiratory syndrome, coronavirus 2. Many viruses, normally the flu virus, when you come in, actually can affect the heart. And we don't usually actually check for it. Sometimes it affects the muscle of the heart, and we call something myocarditis. And sometimes it may affect the area around the heart, a layer called the pericardium, and it causes pericarditis. Or sometimes the area, a space between the heart and the layer of pericardium, cause a pericardial fluid may collect around it. But we don't normally look for it. So sometimes what we are seeing is that the COVID-19 sometimes causes a myocarditis and pericarditis, and be causing problems with contraction of the heart. And when the contraction of the heart is affected, the whole body is affected. So sometimes when we recommend hydration for these patients, with normal viruses, we tell them to hydrate themselves well. We have to be very careful because the contraction of the heart is not very good. And if we give too much fluids, we may sometimes see something called pulmonary edema, where the patient can drown in their own fluids because the heart and lungs cannot manage it well. How does this cardiac injury happen with COVID? These are all theories right now, but right now we know the virus binds to the heart muscle and the lung tissue by ACE2 receptors. And after this, they cause cardiac microvascular damage. With COVID-19, we're seeing patients getting pneumonias, and they get low oxygenation, something called hypoxia. And with this hypoxia, there's damage of tissue as well in the heart muscle, as well as the lungs. And later on in the COVID-19 infection, we've seen a systemic inflammatory response. So all these play a part in cardiac injury. What we're seeing is that apart from patients who have COVID-19 going into heart failure and getting cardiogenic shock, is that sometimes the symptoms may make heart attacks. And this is very scary to the cardiology fraternity, because the same types of ECG findings, that ECG is actually an electrical tracing of the heart, telling you how their heart's functioning. The ECG tracings are very similar to a patient who has a heart attack. And what we see is something with ST segment elevations in the ECG, which we normally see in patients with heart attacks. And they also see that the enzymes, when the heart is damaged, they release some enzymes, and these enzymes sometimes are high in patients. When we look at the echocardiograms, which is the ultrasound of the heart, we see that some of the segments of the heart are not moving well. So it's very important for us to take a very good history, looking for a history of fever and cough before the heart attack, although there may be some patients who have coexisting COVID-19 and heart attacks. And unfortunately, unavailability of rapid tests here in Trinidad, we're not able to test the patients before. There was a study done in Italy with 33 patients who had heart attacks, and all of them were COVID-19 positive, and all their ECGs had showing signs of heart attacks. 45% of them had ST segment elevations, and 80% of them had changes in the enzymes that's showing cardiac damage, which we normally see in heart attacks. And all of them had changes in their echocardiogram, where the contraction of the heart, which is normally 55 to 65%, is normally less than 50% all these patients. Of all these patients, 98% went ahead and did angiograms. And when they did the angiograms in these patients, 60% of the patients had no blockages, meaning that they had no culprit lesion indicating heart attack. So therefore, the COVID-19 patients are mimicking patients with heart attacks. And such that if we were to do angiogram on a patient who was having a heart attack, 90 to 95% chance we should pick up something, but these patients we're not picking it up. So we have to treat every patient with this type of heart attack called a STEMI, like a COVID positive patient. What about other types of heart attacks called the non-STEMI heart attacks, non-ST elevation myocardial infarctions? So what we are trying to do with these patients is, if they're unstable, we proceed towards an invasive approach. But if they're stable, we try to be conservative as long as possible. We are also recommending that if it's possible, not many parts of the world can do this, to have a dedicated cath lab with COVID positive patients on wards, and to test them before taking them to lab, test them before, and prepare labs with special pre and post protocols as if your patient has COVID-19. So what kind of risk factors we're looking at the heart patients? I mean, we know about the diabetes and hypertension, because at least 40% of all our patients at Caribbean Health Care are actually diabetic or hypertensive. There's coronary artery disease, there's chronic renal disease, there's associated respiratory disease like COPD or emphysema. A lot of our heart patients are smokers. There's heart failure and patients who had stroke, which is cerebrovascular disease, and sleep apnea patients. And what we see is the WHO is saying that the mortality of these patients are around overall about 3.4%. But we see patients with cardiovascular disease having mortality of 13.2%, diabetics with 9.2% mortality, hypertension and chronic respiratory disease both have a 8.4% mortality, and cancer patients 7.6% mortality. But when you add the age onto this, patients over 80 years old have a 14 to 20% mortality. Between 70 and 79 years old, they have an 8% mortality, and between 60 and 69, it's a 3 to 4% mortality. So if you have an 80-year-old patient who has cardiovascular disease and diabetes, you're looking at a mortality of 40 to 50%. And that's why we're being very strong about social isolation of these types of patients, because of their risk of mortality by obtaining a COVID-19 infection. With respect to the ECGs, which is the electrical activity, apart from the fast heart rates and the ST segments elevations I've been talking about, there are other types of fast heart rates we're seeing with ventricular tachycardias, atrial arrhythmias like atrial fibrillation, atrial tachycardias, and sometimes in severe distress, some of the patients again complete heart block, meaning that their pacemaker in the heart stops working, and you have to actually put a temporary pacemaker or even a permanent pacemaker in these patients. So, I mean, it's very hard if COVID-19 is mimicking cardiovascular diseases, but we have to make sure and see if we can actually take a good history to even try and separate people who would have had fever before, apart from patients who had chest pain with heart attacks or heart failure symptoms. What treatments are available at this time? Well, we obviously have to treat the underlying diseases like the hypertension, the diabetes, or the arrhythmias, or the fast heart rates. But the treatments of COVID right now are really all unproven. Besides treating a viral illness with giving oxygen because they have low oxygenation, reduction of fever, and hydration, they really have many different theories of what medications could and could not work. Depending on the stage, the first stage is usually like flu-like symptoms where the reduction of fever, hydration, and oxygenation does work. But the second stage is like a pulmonary phase where there's a pneumonia, onset of pneumonia. And the third stage is hyperinflammatory stage where there's like a cytokine storm, which is like anti-inflammatory markers in the body just getting very high and causing a lot of inflammation in the body. So there was a comment made by Italian health minister who said that steroids and non NSAIDs should not be used, but that has been debunked now. For my research, I have not seen that saying not to use steroids for the pneumonia. And with respect to other medications, antivirals, human immunoglobulins, anti-cytokine inhibitors are used. And then the famous hydrochloroquine or chloroquine, which the President of the United States mentioned. There's still not enough data to say these medications are working. Even the hydrochloroquine, there still needs to have more studies, more randomized controlled trials. So these are all from retrospective analysis and about single case studies or even a few patients that have used it and gotten good results. So what I recommend is please do not go out and buy hydrochloroquine and use it because the patients that need it, which are the rheumatoid arthritis patients, the lupus patients, and people who have malaria, they really need to be using these medications. What recommendations I would give heart patients is all patients over 65 with or without heart disease, please use self-isolation. Control your diabetes and hypertension. Continue using all your medications. Use your medication for coronary disease. If you're using anticoagulation for atrial fibrillation, continue using it. If you're using medication for heart failure, continue using it. If you use a sleep apnea machine, please continue using it. Be compliant with your medication, have a stock, and call your doctors for alternatives if you cannot get it. For those with chronic diseases, contact your physician and see if you can do an online or phone consult. Or if it's unnecessary appointments, postpone them for a few weeks. Send the younger families to the groceries, banks, and pharmacies. And even when they come back in the house, it'll be very good to try and keep isolated from the younger members of the family. If you get symptomatic like chest pain, not abating with medications, you're unable to lie flat, you get short of breath from lying flat, easily short of breath, swelling of your legs, heart failure symptoms, or even symptoms like heart attack, which be chest pain in the middle of the chest, feeling heaviness, radiation down the arms, cold sweating, call your doctor and go to the closest E&E. Don't be scared to come for these symptoms. Patients who had recent cardiac surgery, which we have lots of them, ensure you take your meds, stay isolated as much as you can, and no visitors, please. Control your diabetes and hypertension. And if you can postpone your appointment for about 2 to 3 weeks, please do that. Patients who had recent heart attacks or recent stent placement for angioplasty and stenting, ensure you have your antiplatelet medications. That's like your aspirin or your clopidogrel, Plavix, ticagrelor, Brilintas. Because if you don't take these medications, the stents in the heart can block. They can actually get thrombose and you can die from that. So those medications are very important to have and have a few months supply. Continue your structured exercise program depending on what type of cardiovascular disease you have. And for mental health, utilize your Skype, your WhatsApp, your Zoom to keep in contact with your family relatives because this is very important during this stressful time. And start a home garden. It's healthy and economically viable and is good mobilization at home. About wearing masks. So initially the WHO recommended that only sick people and medical personnel should wear masks. And what they said is that putting on a mask on a sick person prevents him from transmitting the infection. However, this is my opinion, and the other scientists have suggested as well. You really can't duck a cough or a sneeze, you know. So if you have on a mask or something to prevent you from inhaling, it will help. In closed rooms with poor ventilation and airplanes, small spaces, aerosolized particles can travel, and having a mask can reduce chances of inhalation, depending on the type of masks. Yes, they have recommended that N95 or N99 masks, but the ministers have been saying try not to use these masks because we will be in short supply sooner or later and the medical personnel will need it. What does a 95 mean? It means that it blocks 95% of all the very small particles. So if we all wear a mask, the risk of transmission in the community should logically decrease. Another recommendation we were giving doctors is actually if you have a procedure that can be done at the bedside, please do it. Try not to take the patient to the theater or the cath lab, because these areas are we don't have many of these areas, and if they get contaminated, we will not be able to take patients inside. We're actually presently building a plexiglass screen where we can do procedures on patients through a small hole to help prevent contamination or transmission. What has been done in the cardiology societies in the world? But the cardiology societies in the world are asking to do only essential elective work. Patients that need life-saving procedures or unstable. All non-essential work is being postponed for a few weeks, maybe 4 to 6 weeks at this point in time. These include patients waiting with stable angina for coronary angiograms, stable peripheral vascular disease, that is the disease of the legs, the blood supply of the legs. Unless it's critical limb ischemia and you have risk of amputation, we would not do any procedures on them right now. Electrophysiology, cardiology procedures, this is like pacemakers. We're still performing pacemakers, but these are usually life-saving. But electrophysiology procedures where we ablate arrhythmias, which is fast heart rates like SVTs and so on, we are postponing them for a couple of weeks. Structural heart disease, such as Watchman's or closure of heart defects, we are postponing them for a couple of weeks as well. But patients who have to change the aortic valve via the TAVI, this is the non-surgical procedure, you can change the aortic valve. They are usually symptomatic and a high risk of sudden death, so we will still proceed with these procedures. Most staff in the world are trying to use virtual clinics, and they're rotating physician and staff depending on how many physician and staff they have, staggering 1 week off, 1 week on. For this reason, the symptomatic patients who become affected, it takes 3 to 5 days, 95% to show symptoms. So that's why they're staggering 1 week off, 1 week on. And over 65 medical staff, they actually ask them not to come out to work. What are we doing in St. Clair Medical and Caribbean Heart Care? Well, we're following all the guidelines, the European Society of Cardiology, the American College of Cardiology. With our STEMI patients, which we're seeing them a little more frequent than normal, they actually are coming in. We're actually treating all of them as if they're COVID positive patients. If we have time for non-STEMI patients, we will try and test them before, because it takes 24 to 48 hours to get a result back. And if we can test them before and see if they're positive, this will help with their management. We're limiting visitors to only one patient inside the hospital. If none at all is possible, we're screening the visitors at the entrances. We're screening the visitors on the telephone. Nurses are taking precautions, especially with barrier nursing, because they work in different hospitals and they can be asymptomatic carriers. The clinic, we're only seeing patients with heart failure who had a heart attack recently, unstable angina, or recent emergency procedures. And all of them all the other procedures are being postponed to 4 to 6 weeks. We are actually leaving the patients sitting in their cars after being screened on the telephone, and they walk straight from the cars into the offices. We try not to get them into the waiting room as long as possible. And we're looking into video conferences and virtual clinics very soon. If it's possible and procedures need to be done, if we can test the patients 24 to 48 hours before, we should. Unnecessary elective procedures can risk families, staff, patients, and the institution, and waste valuable PPEs. Use up space in the hospital, even ICU beds unnecessarily, and increase the risk of spread to the public, because we have to increase the amount of workforce by more escort workers, additional nursing staff, and medical personnel. So waiting for these procedures for 4 to 6 weeks until we get more data, I think is the appropriate thing to do. So what's the take-home message for patients with cardiovascular disease? If you're having symptoms of a heart attack or heart failure, you should come to the hospital. When we say don't come to the hospital, we are meaning for simple things. But if you're having symptoms, please come, because a lot of patients are succumbing to the disease by not coming to the hospital. Stay at home, be isolated. This works to help you from getting the disease and reduce the spread of the disease to your fellow citizens. And manage all your other comorbid conditions like diabetes and hypertension by taking all your medications. Make sure you have stock. Watch your diet. Get proper sleep. Use your sleep apnea machine if you have it. Do prescribed exercise. Call your doctor if you need any advice. So to my fellow human beings, please listen to the guidance from your government and Ministry of Health and doctors, and be safe. Wear masks and stay home. And I thank you again to my Caribbean Heart Care frontline staff, the cardiac team, the cardiologists, the surgeons, the nurses and technicians, and the admin frontline staff who are still around and helping us through this tough times. Good luck, everybody, and be safe. Thank you.
Thank you for all of that valuable information, Dr. Rampersad. We do have a few questions, and we do have a few attendees who weren't able to join at the start. So I'm just going to let them know that there is a Q&A or question and answer button somewhere on their screens that look like 2 chat bubbles if you wanted to send questions. We have a question here. You mentioned that the treatment of the underlying conditions such as diabetes, CVDs, and HTN is needed. Some of the research I have read indicates that medications given for the management of these conditions increase ACE2 receptors and can make COVID more severe. What is your take on this?
Okay, so the European Society of Cardiology debunked this about a month ago. Yes, I should have mentioned that the ACE2 receptor antagonist is a medication used to treat hypertension in cardiovascular patients, but this does not affect patients with COVID-19, and they still recommend please take your medications to control your hypertension, because uncontrolled hypertension can cause further problems with patients with COVID-19 or even cause heart attacks or strokes. So please continue your ACE2 receptor antagonist medications.
Okay, and then I have another physician question here, and then we will get on to some medical layperson questions. In cardiac cases, are most of the deaths in COVID patients from the cardiac situation, or is it the respiratory problems in other non-cardiac patients?
So all we have is information with respect to patients with cardiovascular disease who get COVID-19. We know that the mortality is like 13 to 14%. The data with respect to what they are succumbing to with respect to respiratory disease, pneumonia, or the hyperinflammatory situation, we don't have a lot of data with respect to that. I think that data should be coming out. I don't think a lot of the countries are giving that data out right now because there's so much death right now that they're not giving out all the information with respect to autopsies. They're not even having time to do autopsies. So I'm expecting to get more data with respect to how many patients are dying with respect to the respiratory ailments. But we do have data with respect from China and Italy with respect to cardiovascular patient with cardiovascular disease as the only risk factor. They about 13 to 40% risk of mortality. Diabetics about 8% and hypertension about 8%. So that's excluding age. So when you add age onto that with respect to comorbid conditions, you can see what the mortalities will be with a patient. With respect if they will die, a cardiovascular patient will die with a respiratory ailment, I don't think I have that information.
Okay. And we have a question from an attendee. If you've come into contact with someone who's traveled in the past 21 days and are having fever and body pain over the last 4 days, should you get tested for COVID-19?
Well, I will say yes if you can get tests. I mean, there are some places, I think the Cuba Health Center and so on, if you call in the hotline and you mention to them you've been with a person who is probably COVID positive or have symptoms, they may actually test you. They're doing a little more tests than normal. But I will say yes, you should get tested if you can get tested. If you cannot get tested, I will actually isolate yourself from your family and actually try and keep in contact with your doctor to see if the symptoms worsen, because 80% of the patients may just have mild flu-like symptoms for about 2 weeks and it may not progress. But if you find you're progressing and you're starting to get shortness of breath, difficulty breathing, and the fever is not abating, you probably need to go into the hospital and call the hotline and they will advise you what to do.
Okay, and Dr. Rampersad, would you say even if you are able to get a test and you have to wait a few days for the officials to come by, that you should self-isolate during that period?
Yes, I will say so.
For a positive.
Yes.
Another question, what happens if you have a small chest pain and pain in the left arm and cold, no fever?
Okay.
I believe that this second question is related. Did the flu shot 3 weeks ago and a few days after got the flu with 2 days of fever runny nose but lingering flu symptoms, lots of sweating in the past 3 days, been taking meds and decided to do walking exercise for 30 minutes in the past few days, feels a lot better. Diabetic, hypertensive, heart monitoring.
Okay, well, I mean, I mentioned at the start, if you have a flu, you should rest. That sweating out a cold is not actually advised, as because most viruses can affect the heart muscle and the area around the heart. So it's better not to go and try and exercise. It's actually best to rest, take medication, reduce your fever, hydrate, and wait it out and see if the symptoms abate. If the symptoms are not abating and actually getting shortness of breath or a fever and it's continue, I think you should contact your doctor or call the hotline. With respect to a cardiac patient with, this is the difficulty we're having. Some patients getting chest pain because of a flu, because of a virus, and some patients get chest pain because it's acute syndrome, acute coronary syndrome, a heart attack. But usually it's very difficult to tell, especially in a diabetic patient, because these patients sometimes are asymptomatic or have very mild symptoms. But if you have no coronary artery disease and you actually start to get symptoms like chest pain, radiation down your arm, it's severe, and cold sweating, you can think you have to rule out a heart attack. If you do have coronary artery disease and you probably know a little more about your symptomatology, you can actually gauge it and speak to your doctor and tell him, listen, this is the symptoms I'm having now, and he can help you with respect to if it's a viral symptoms versus the cardiac symptoms. But really, it would be nice if we weren't sure to actually just go into the hospital and check. But nobody really wants to go in the hospital just for mild symptoms. But sometimes mild symptoms can be acute coronary syndrome or heart attack. So we have to be very careful with respect to, and take each case with a good history, because we're doing the histories from the telephone. And if you can get an ECG from these patients, from some of the health centers, they actually, or some cardiac enzymes, they can actually give us a little more information if you need to proceed to the hospital or not. So we just have to give a very good history to your doctors, and if you're not sure, call them and see if they can help with diagnosing if it's a flu-like symptoms or if it's a heart cardiovascular symptom.
Great. Well, thank you so much, Dr. Ramprasad. We had some great questions, and those were very, very helpful answers. You gave a lot of information for the health community, the healthcare community, to sort of take care of their patients during this challenging time. And you gave a lot of good tips that we can all follow, whether we are cardiac disease patients or not. So thank you for taking the time to talk to us today. And I want to thank all of you who attended today's live webinar. Without you, the experience is not the same. You're creating a positive sense of community when you join us, bringing energy with your questions, and we welcome you to return for all our webinars this week. The details about webinar registration can be found on St. Clair Medical's Facebook page if you'd like more information. So thank you again, Dr. Ramprasad.
Thank you, Alyssa, for the opportunity.
And we wish everybody a wonderful and productive afternoon.